and you badger them, and started doing all this stuff with him. That's how we test. Hold! Okay, that's good. Wait a minute. What do you mean that's good? That's nothing. Anybody can hold that. All you need is 10% of your motor units to do it quick maximal contraction. And then gradually we convinced him to do it this way, and now of course finds all sorts of differences. The smaller pauses, of course, you really need to do it very accurately, otherwise you're not going to pick them up. What position is a muscle strongest in? Short? Neurophysiological, okay. A movement is strongest in mid-range. Don't get the two confused. Why? Because its angle of pull is going to be maximal in mid-range. Look at the angle of pull there, look at the angle of pull there. Where's the maximum? There. But what about the biceps muscle? Where is it capable of producing the most strength? This is where we torture these poor rats and different things by taking their muscles out of their body, putting them on contraptions and saying, okay, does that contract stronger if it's long or if it's short? The answer is long. When a muscle is in its longest position, it's capable of producing most force. Yes. So in a short position, we have this muscle physiologically at a great disadvantage. If it's at a disadvantage and we ask him to produce maximal contraction, what's he going to have to do? He's going to have to use more motor units, isn't he? He's going to have to use more motor units if I get him in a short position. So when we're testing, if we can, we get them in a shortened position. Give them a disadvantage. We want them, especially these big hunks, we want them at a disadvantage. We want to be able to overpower them and at the same time recruit maximal motor units. Sometimes we can't do it. The leverage doesn't work out in a short position, like quadriceps. They get that knee locked in there, and as I said, like the soccer player, you cannot break them, even if you jump up and down on it. So we use leverage where we can't use a short position. But the idea is to test it in as short a position as we can, if it's possible. The other thing is our command. Let's have somebody that doesn't know what I'm about to say, so I won't use you, Randy. Oh, come out here for a second. Just sit on there. Feel like a guinea pig? Okay, I'm just going to let this down a little bit. Get you stable till you... Okay. When you're doing muscle tests, in a sitting position, make sure that the patient can reach the floor so they can stabilize and get everything. Otherwise, very often you're testing their coordination and not their muscle strength. So, here we go. Let's test elbow flexion. Okay. So I just test that. I get him to pull against me. That's good. Now, two commands. See if you can notice the subtle difference. Okay, just bend your elbow. Bend your elbow up. Overpower him. And relatively easily. Okay, don't let me straighten your elbow. Keep it still. Different. Oh, it's his second time. He's getting used to it, right? Okay, bend your elbow. Very different. What's the difference? How come I can overpower him by saying bend your elbow, and yet when I say to him don't let me straighten your elbow, he's strong? Yeah. Your mind presets your motor unit activity. It looks at something and thinks, okay guys, we're going to need a lot of motor units for this thing. Get ready. Otherwise you walk up to it thinking it's a light object, and that's when you hurt yourself. Wrong settings. So I put the idea in his mind, thanks, that's great. I put the idea in his mind, it's going to be an eccentric contraction. Get ready for an eccentric contraction. And he's stronger. How much stronger? What's the difference between, and this is exactly the same muscles, it's the same movement. And because it's isometric, we can't talk about oh, okay, this must be the locking mechanism in the myofibrils, actin myosin links and all this kind of nonsense. Can't be that, can it? Has to be something different. It's preset. If it's preset, what does it have to be? Neurological. It's a neurological phenomenon. An eccentric contraction recruits 17 to 20% more motor units than a concentric contraction. Okay, a eccentric contraction recruits 17 to 20% more motors than a concentric contraction. How do we know that? Because one of the guys who developed the King Kong, which is the only machine that is able to test eccentric versus concentric strength, the Dynatrack and the King Kong, one of the guys that developed it is my partner. King Kong and the Dynatrack are actually made in BC, in the Fraser Valley. And this guy did all of the work, the clinical work with the developer. And one of the first things we did was test concentric versus eccentric, and the clear data shows up. In the lower limbs it's about 17.5%, but in the upper limbs it's much more, closer to 20% difference between eccentric and concentric. Simply by saying, don't let me, you put the idea in your mind, I'm going to try and straighten your elbow, don't let me. Ah, that's an eccentric command. I mean, you don't think in those terms, neither does your patient, but their brain does. Of course, depends on the patient. Sometimes it takes you a while to get even that basic concept across. So what we're trying to do is we have a patient here, we say, okay, he may have a palsy. If he does, he may still have enough motor units to be powerful. And I have to work a way of getting all of his motor units to work and stay working for a few seconds. Because if he has a palsy, he's lost 75 to 80%, he won't be able to sustain that as long as I've got all his motor units together. So to recap, maximal contraction after a slow build-up with sensory and vocal facilitation in a shortened position following an eccentric command. So yeah, muscle testing, key muscle testing is complex. It is not simply a matter of saying, okay, let's see how strong you are, push against me. It doesn't work like that. To get the accurate readings, we have to do it very specifically. Okay, Randy, can I use you now? Sir.
You're telling him to push against you elicits a concentric contraction. Is that right?
Yep. Lie on your back for me. So just to test hip flexion as an example, bend your knee up. Keep that knee there. And don't let me push your knee down. Slow build up to a maximum. Now how do I know it's his maximum? Experience, because I know if I give him an ounce more force, we're going to break his hold. So I take it up. Now initially you may want to break, some of the teachers say, no, you have to break the hold to know you're taking him to the maximum. Sometimes that can be a little bit dangerous. Slow build up, if you like, to your maximum is probably going to be accurate enough, like hold, relax. And it's going to be difficult, especially for the women in the group, to be able to break some of the male holds. And this is another physiological feature that you have to understand. Watch your commands, you can get hurt. Didn't anybody run into that trivia question? You know the game trivia? There's a question in there which I found fascinating. I don't know how it ever got in there, but one of the questions is, which animal has the equivalent power output of a 25-year-old woman? So that's why it caught my attention. I thought, strange question. This guy must have some very interesting parties. The answer, 65-year-old man. If you take people trained in an equivalent manner, athlete to athlete, the power output of a 25-year-old female athlete will match a 65-year-old male athlete. We had a physio who was really badly hurt in Ontario by testing a muscle like this, and the guy couldn't get the command, and she just said, okay, look, I want you to stop me, pick me up and throw me across the room. And the guy did. It was a very unfortunate, it's one of those unfortunate instances, a comedy of errors, because the guy was being rehabilitated for a fractured femur. He threw her across the room, she hit the wall, went whack, completely unconscious, and he fell off the bed and broke his other leg. And the reason we got to know this was because this whole thing then came to court. Because this athlete sued the therapist and won. And the judgment that came down, following all of the expert testimony, was, as a physio, you should have known that a male athlete can do damage given the wrong commands. They can. So, we're going to do all these tests in a manner which saves us, protects us as well as everybody else. Now, the heavier you are, the more your advantage. The lighter you are, and again, this is another male-female, most males are heavier, given the same build and everything, so they're at a slightly better advantage. But even so, I have to do this several times a day. I want to get home in some reasonable fashion, not like a droopy rag. And once I've finished, and you'll notice this, once you finish a scan, muscle testing and a scan, you're sweating. Well, you should be, otherwise you haven't done it properly. So, look at my stance. I'm not going to try and break his leg muscle with my triceps. I'm not that stupid to look at this bulk versus this bulk. So what I do is I use my body weight. Now this is, okay, now we're comparing. Okay, and I'm using my legs, like this. Don't let me push your hip down. Good, see I'm giving you my gastrocs and everything. Okay. If he has an instability, spondylolisthesis, he'll go, oh, that's painful, I can't do it. Bend your knee up, grab that, hold that right close to your chest. We fix his instability, now we can do it. Oops, we had his shirt off, we'd be able to do it. And without pain. And this is extremely important because weakness of psoas is a very important sign. Where can we get weakness from? It could be a palsy. How common is an L2 palsy? It's very rare. The more likely answer is a tumor or a fracture, something serious. So if he does have weakness in psoas, we need to find out. So if it's painful and it keeps breaking his hold, it's not good enough. We have to work out a way of making it painless so we can test it. So that's one of the ways around it. Quadriceps, this is tricky. This is a powerful muscle, especially eccentrically, which is what it spends most of its life doing. So in this position, this is the way I do it, and somebody around his size, okay, keep your knee in that position, don't let me bend it. Now, so I take him up to his maximum, and I can still got enough power there, using my weight, to overcome his contraction. But for many of you, it's going to hurt your arm, or you're not going to be able to do it with the one arm. So there's various other ways. Lie on your stomach. You have to tailor this to your patient. If you're treating somebody, female of your own size, you could do it that way. If you're treating somebody who's bigger, then you have to find different ways. Don't let me push your foot to your bottom. Hold. Now you get your body into it, and it's a lot easier to overcome that muscle. Stand up for me. Some of the really big guys, bend your knee. I have to use this, because the only way I can actually give them a sustained hold. Don't let me lift, and I get my legs in and I just come up. Now he's holding his entire body weight on his quadriceps. If he has a palsy, he's not going to be able to do that for very long. That's a way of sustaining it. But the best way for many of you is going to be prone knee bending. Stay on your back from. Dorsiflexion. Small muscles, very powerful.
On the prone knee bending, you had his muscle in linked position.
Yes, that's what I'm saying. That's the instance. When I mentioned that, that's exactly what I was thinking about, was the quadriceps. That's the instance where getting the muscle in a short position is its powerful position. The knee's locked, you can't do anything. You have to at least bend it out of a locked position. But then the muscle is so powerful that how do I overcome that? You know, and the best way is to get better leverage. So although we put the muscle in a physiologically stronger position, from our point of view, we've got him at a much bigger disadvantage from a mechanical point of view. Dorsiflexion, pull your foot up for me, toes up, towards your head. Good. Okay, now, don't let me push your foot down. Look at my stance. This isn't going to work. Okay, don't let me push. This is going to work. I've got my glute max involved in this. And even though I'm using my body weight and my legs, I can just about overcome that movement. As I say, take a male athlete, trained, you pull against him like this, he can hold with maybe 10% of his motor units, doesn't have to work at all, and you cannot break him. This is different. This is body weight and leg muscles versus his leg muscles, and you can probably match it. We take a more powerful group, the plantar flexors, we cannot break it, period. It is so powerful, and the lever is so short, we cannot possibly overcome that. So how do we get around that? Stand up for me. We will use multiple repetitions. So we're not going to just hold out for 3 seconds, we're going to do rapid movements. And in that way, hopefully, cause neural fatigue. So I use his arms like this, okay, lift one foot off the ground, go up onto your toes on the other one 10 times. Now, I'm not giving him my arms to lean on because I'm a nice guy. I'm doing that because if he starts to weaken, he's going to lean on me, and I'll think, okay, just do another 10, and then it will show up. Most of the time with an S1 palsy, you'll get maybe 3 lifts, and then it's dead. But sometimes, if it's a minor palsy, you have to go up to 20 times. Back on the bed for me. So that's an example of the different ways we have to test to overcome some of the power. What about the little muscles? So, okay, we're doing his extensor hallucis. Now it's like, okay, now we get our own back. Don't let me bend your toe. Well, of course, you can overcome it very easily, you know. So use your fingertip. You want his maximum contraction in a controlled fashion, so there's no point using a lot of force. You know you're going to overcome him. One of the problems is the tendon of the extensor hallucis is bound down by retinaculum at around the distal part of the metatarsal or the proximal phalanx. So pull up for me. There's this, I don't know if you can actually see it, you can feel it. There's a retinaculum. Sometimes in sprains or athletic injury, that ruptures. So they don't have that and they lose the advantage. So what you do is just routinely hold it down, the tendon down to the metatarsal, to give them that advantage anyway, so you don't have to worry about whether they have it or not. Now, don't let me bend your toe. Nice strong contraction. Watch what happens if I don't do that. Don't let me bend your toe. He can't hold it at all. I mean, his is quite stretched, so I can't. What does that mean? It doesn't mean anything. I can feel he's contracting, but is he weak? This way, hold. No, he's strong. Now I can take him to his maximum, hold it for 3 seconds, 4 seconds. I know it's his maximum because I can feel I'm just about to bend it there. So we use an appropriate stance and appropriate leverage according to the muscle group that we're dealing with. Hamstrings, again, another powerful group of muscles. The most effective method is to do the prone knee bending. So lie on your stomach for me. In this position, don't let me push, hold, where you can get some leverage involved in that. One of the problems with that, of course, is it tends to often give them Charlie horses as they're contracting, so it slows you down a little bit while you get rid of the spasm. Lie on your back. And if they have a painful knee, it's not a good technique, come close to the edge. The one I use routinely is this one. I get my hand here, just really to hold it, but I'm going to be lifting with my body. And fix the knee here. And don't let me lift your foot up. So I can just straighten my legs and hold him there. So, and hold that for a few seconds, relax. Again, using his body weight to give the force, rather than me having to apply it manually. Lie on your side. The L5, looking at the hip abductors from this position. Remember, the person is being tested because they have a back condition. They have a back condition because they're probably weaker in the back than they would normally be. When we test abduction like this, we are assuming that the pelvis is stable. And the pelvis is being stabilized by which muscle particularly? In this instance, quadratus lumborum. Well, quadratus lumborum, of course, will weaken if you have a lumbar problem. So what you may be testing inadvertently is side bending of the lumbar spine. So get your hand here, you fix it, get on top of it, push that pelvis down, and then you come above the knee. Some severe injuries have occurred with people using this length of lever. It's very tempting, especially in the big guys, but it can be very harmful. So we're just above the knee, pushing down like so. I go right onto my toes, I lean over on the top of him, and then I just let my weight off to come down. On your stomach, gluteus maximus. No good testing hip extension. The hamstrings are too powerful. And in any position, they work a lot harder than glute maximus, because glute maximus is not a hip muscle. It's a trunk muscle. Its function is this. That's what it's there for. So testing the hips doesn't work. But Syriac ran across something that was very, very interesting. He noticed that in pauses of S2, the ability of somebody to tighten their buns was lost. They could do it on one side but not the other. And simply that's what we do. Say, okay, tighten your bottom. Good. Hold that. And then we use what we call a pressure inhibition technique. Now if he's strong and can hold, I just push into the muscle mass of glute max. Say, don't let me push down. That's good. Keep it there for a second. Don't let me push down. That's good. And that's the most accurate form of testing. Ironically, breaks all the rules that we've been talking about. It's the exception that proves the rule. But if you try and test it any other way, and we've done that on the Dynatrack and King Kong, you cannot get the hamstrings out of the picture, and they're too powerful. So if they're functioning normally, they can give you a false negative testing hip extension. So this is the best way. Somebody has an S2 palsy, has a very flabby bottom on one side. So I suggest you look at them, you see the buttock drooping, a couple of inches down. The reason is it's lost its tone from the palsy. When you do this test, they can't tighten. It feels floppy. When you push in, there's no resistance. On your back for me. The other S1 muscle that we've tested is the everters, and you look at that, and one of the problems with eversion is a very short lever, just the outside of the foot to push against. And again, it's no good doing this because you cannot get enough force. So what I do is this one, put the heel of my hand on the outside of his foot. And in the squat position, I'm going to use my body twisting like this. Don't let me turn your foot inwards. Hold against me. Come on, don't let me turn it. And now by using my legs, my right leg is doing the work, I can overcome his hold. So this part of the scan is like an athletic event for both of you. And sometimes when I see patients from other therapists and I'm doing this scan, you know, and the patient will go, "Whoa, boy, that's hard work," you know, and you know he hasn't had it done before. Not to that degree. It is hard work. It's hard work for both of you. That's why I said, protect yourself, use as much leverage as you can to disadvantage the patient, and use your body.
What position do you like to
In the scan, I don't routinely test the adductors, but what I will do is simply this. I get this leg out of the way so I can shorten the adductors in this position. Okay, then I'm going to stabilize the pelvis. Don't let me pull your knee towards me. It's a good bed. And then we can pull like that. If you do it, you know, with this kind of length of a lever, you can actually produce an adductor tear, so be careful. Yep, you can use side lying, lifting the legs up, but then you get involved the other side muscle, the other group of muscles. Lie on your side. I've seen it tested this way, lift up, both up, and then pushing through this. Of course, you've got these muscles involved here. Lift up here, hold, don't let me push down. Again, that's kind of a coordinated movement. Your patient may not be able to do it, but if they can, that's fine.
How do you test? I mean, when you did the hip extensor test, when you had them tighten and push in with your fist, how do you grade that?
Absolutes. You've got to think absolutes. A palsy is a palsy. There's no maybe palsies. It's either weak and fatiguing or it isn't. And I often see people teaching this say, compare to the other side. I have to test the other side to compare the strength. Bull. Why are you comparing the other side? What's that got to do with this nerve root? It's either a palsy or it's not a palsy, regardless of what that side has. I mean, if I were to compare your sides, I'd really be in trouble, right? So each limb, each muscle group is tested on its own merits.
Okay. Suppose you're trying to decide, you see a patient acutely and they do have a palsy and you're retesting again to see if it's getting worse, then what do you do?
Yeah, so you're looking at between 2 and 0, right? On the, grading it. Like a 2 you can overcome, so that's obviously a weaker muscle. But it's not a matter of, to grade a muscle, you have to be able to move the joint. But we're not moving the joint. This is an isometric contraction. We're taking it up to its maximum and keeping it still.
Right.
And we're saying he can hold a maximal tetanic contraction for 4 seconds.
Okay.
Or he can't, which is a palsy. If he is getting worse, we've already picked up the palsy, we cannot pick it up worse or better. Other than the fact that you'll notice that last time he was able to hold for 2 seconds, this time he can only hold for 1 second, that kind of thing. I'll show you in a minute how we do repetitive testing, and that may answer your question a little bit more. But it's very important to realize that we're testing a different thing from muscle strength. We're testing nerve conduction. So we don't have to grade the muscle because it's not relevant in this instance. Look, for example, at somebody who broke his leg. Okay, fractured his thigh, and now he's coming in with what looks like a lumbar pain. Last year fractured his thigh. So we look at this and it's wasted compared to the other side. So for one thing, that's useless to compare one side to the other. It's not going to help me. How can I take this weakened muscle and know if it is a palsy? It's going to be weak, right? Mm-hmm. So how do I know if a weak muscle is weak because of a palsy or because it's a weak muscle? We'll look at that in a minute. So, on your back for me. Just to run through again, in the sequence, we'll practice that before we have a break. Bend your knee up for me. Okay, don't let me push your knee down. Come on, hold, hold, hold. And relax. Okay, just keep your heel off the bed. Don't let me push your heel down to the bed. Come on, hold it, hold it, hold it. Relax. Pull your foot up for me. Keep your toes up. Don't let me push them down. Come on, pull up. Pull up. That's good. Hold it. Relax. Pull your big toe up. Don't let me push down. Relax. Turn your foot out. Don't let me push your foot in. Relax. Lie on your side, facing that way. Bend your underneath knee. Lift your leg up for me. Don't let me push your knee down to the bed. Keep it up, keep it up, keep it up. Relax. On your stomach, notice the first one, of course, that we do, which we're doing standing, is the gastrocs. Needs to say, okay, bend your knee up here. Now, don't let me push your foot down. Hold it. I think most of you are going to prefer that test. And relax. Tighten your bottom up for me. Squeeze them together. Good. Hold it there. Don't let me push. Keep it tight. Don't let me push. And relax. Got the idea? It's physical. It's loud. You're an authority. You've got to make that quite clear to your patient. They will do as you tell them. Otherwise, this whole assessment is a waste of time.
What's your alternate for L4?
Ah, good question. You can use the hip abductors, which are basically 4-5. You can use the quadriceps, which are 3-4. The one I use is inversion. Lie on your back. In some books, actually, they put this down as S1, but I'm not quite sure why. Because certainly in L4 palsies, this is one of the muscles that goes with a dropped foot. Okay? With a dropped foot, that's what you're going to find. You lose dorsiflexion inversion. Those muscles always work together as a set anyway. So just turn your foot in, hold, don't let me push your foot out. Same as testing eversion. And the sequence I use is just developed from the old days, like, you know, all this information plus everything else you're trying to learn. It's God, I'm never going to remember this. So you just do it in a sequence. 2, 3, 4, 5, S1. Go through it in sequence. That way I don't miss anything. And you do it enough times you don't have to think about it anyway. Okay, any other questions? If not, we're going to look at some of, as we said, some of the things we can derive from this after the break. But let's practice this before the break, so we get to know the techniques.
I want to talk about hand placement. When
Okay, so we initiate the test and we find they can't hold the force to a maximum to our satisfaction. Maybe it's a weak muscle. Maybe we're expecting more of this muscle than it can actually give. It's not a palsy at all. So how can we differentiate those? We use repetitive testing. On this force time graph here, this is what a normal test should look like. Say to the patient, don't let me push you, hold it, hold it, hold it, hold it, gradual build up and then to a maximum, and they hold in terms of seconds indefinitely. Okay. Here's a palsy. Same thing, they can reach their maximum. Most often these guys do reach their maximum, but they can't hold it. And it drops off. So we find that, we say, okay, now, I'm going to do repeated testing 3 or 4 times rapidly. So we're going to fatigue the muscle now with rapid, repetitive testing. Hold, relax, hold, relax, hold, relax. And when we repeat repetitive testing with a palsy, we find, okay, well that's interesting, this time he didn't quite reach his maximum. Oh, this time he didn't get anywhere near it. And this time, and then gradually he's getting weaker and weaker. That's very typical of a palsy, fatigability. So this is one of my questions about grading. How do you grade that? Are they getting weaker with every test? Where are you going to put your grade? This one or this one? So, say most palsies on your system, by the sound of it, you're using it, we'd be putting about 3 or 4. Because eventually, they have no strength at all. Once you fatigued it, you can just blow on it and they won't be able to hold the contraction. Here's a weak muscle. Hold. I find they peak there, so I hold it. Ah. But they don't break. I'm not quite sure. It's a weak muscle. Was it a palsy? Maybe I didn't do enough force. So let's repeat it. We repeat it. Hold. 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 It's consistently weak. Rather than a palsy which is inconsistently weak. It's getting weaker. Progressively weaker with repetitive testing. A weak muscle, for whatever reason, and we're talking about a muscle phenomenon now, a weak muscle is going to be consistently weak. Every time we test it, it'll be able to put out the same power. Of course, fatigue is a neurological phenomenon, not a muscular phenomenon. Here's the classic. Say to them, hold up. See that one? This is what I call the Laurence Olivier effect. There's the patient, you're doing a scan. I mean, we had no indication they've got pain in this area here at all, coming with a whiplash or whatever. We start testing their muscles and it's like, oh. Now I want you to hold it. We badge them. Come on, hold it strong, strong. Ah. So we give them the warning about, you know, you got to do this strong, go over the pain, but they just can't, you know. Oh, like that. So, what conditions? There's only one condition where that phenomenon can actually exist as a clinical entity. Because if it were painful, what do people do when you create pain? Yeah, they turn up or they withdraw. So it's like they would do this, right? Ah. Oh. And that's what happens if you're testing an elbow that's really sore. Don't they? They do that. Or if you're doing this one, they try and pull back. But they don't let it go. That would be terribly disadvantageous. It's neurophysiologically impossible. You don't just let something go because it's painful. It will create more pain. Even your pain inhibition. They let it off. It's like a lead pipe resistance. You can feel it going. But this one is very unusual. And there is one condition. Anybody know what that is? One condition where you run into this. Maybe many of you haven't run into these people. Again, it's another condition that's on the way out. Well, yeah, the secondary gain, that's what that is. But what I mean is one condition where that could be a genuine response, and that's muscular dystrophy. The muscular dystrophy patients, they hold the maximum, and it just neurologically switches off. They can't hold that contraction. Yes. So that's what I say to the patient. I just look at them and I say, well, I've got some bad news. I don't think I can treat you. And they say, why? And you say, well, you're either crazy or you've got muscular dystrophy. You should go and see somebody else. Get rid of them. Because if in the initial treatment I'm getting this kind of response, what the hell am I going to get when I start treating them? Never mind, you know, in the assessment, and they're not going to do their exercises. The whole thing is obviously some kind of game to them, so I don't tolerate that. I'm very strict.
What do you actually say to them now?
I say to them, I think you need to go back to your doctor, and because there's nothing I can do for you. And then I'll phone the doctor and I say, you know, this guy is as genuine as a $3 bill, and I've got better things to do with my time.
Well, how would you document it, though?
Inconsistent findings, query, I put litigitis and all these other things on there. So that if ever anybody requisitions my records, it's right there.
Do you ever call it let go weakness? I mean, you determine a certain type of weakness, like a let go, or any terminology?
No, I just call it it's an inconsistent finding. In other words, it doesn't fit any known pathology. If I've been referred the patient from another therapist, then that's a bit different, because you know, you have to be careful because there's another relationship involved there. So I'll just go through the rest of the assessment, and then I'll talk to the therapist and I'll say, you know, I don't think this guy is genuine. And these are the reasons. There's various tests that we do, and we should document them really and put them in a list, but for insurance cases especially, there's certain things you can look at, and if there's enough of them, you know this person is being fraudulent. One of the classic ones, in the neck especially, but in other areas, is how much movement does the patient offer? You say to the patient, turn your head to the left, and they go, you know, you ever notice that tremor? Thank God, if that was a painful neck, that would be really painful to do that. So what you do is you say, like that, or when they're in lying, you roll the head from side to side so they don't know what you're doing, and you think, do you know? They gave me 10% of the actual movement they have. Anybody in pain, severe pain, would give you more. They'd give you like 80%, right? And they'd be blocked, and you couldn't get past that, or maybe a little bit. So what I do is I say, if anybody gives me consistently, less than 50% of their actual available movement, I think they are trying to put one over on me. Cliff Fowler, I mean, we joke about this, but I actually saw him use this on a patient. He calls it the Wasatch test, where, you know, you get these patients, we were looking at this patient together, it's like, does this, and Cliff goes, my God, what's that? What? You know, and then you get the patient, and you say, turn your head to the left, and they do the same thing. They're so stupid, they don't even know what's happened. So a lot of the patients, of course, are unaware of the fact that we know, when you've seen enough pathology over enough years, you know what it looks like. And you know what these other patients look like. They're very different. So there's other tests. This is one of them. This, you know, inconsistent give. I mean, if I have a patient that does this consistently, that's a pain inhibition curve. The guy will go, ah! He'll let it out slowly, like that. But it'll be the same each time I do it. It's not going to fatigue. So that's a normal curve. But this sudden, like that, very unnatural. And as I say, no neurological reason for it other than they have muscular dystrophy. So I let them know that's a possibility and they should go back to the doctor.
So I guess the difference between a weak muscle and the normal muscle, I mean, they're basically the same. It's just a varying degree, and that's subjective on your part.
The shape of the curve is different. When you compare it to the other muscles in that region, and you compare it side to side, that's when you want a comparison side to side, then that will show up. And since you're doing both sides, you get the comparison anyway. You look at the quadriceps, you say, boy, that quadriceps is a lot weaker than the other side. but it's consistently weak. See, look at dangerous pathology. What can give us a weak muscle, a consistently weak muscle? Not talking about a palsy. No, that gives us a palsy. It looks like a palsy, a tumour. But it looks like a palsy throughout the whole limb. I don't know if any of you have ever seen a tumour. A classic example was one of the ones that we got in, which was a young guy, 17 years old, who had a tumour in the lower part of his femur. He was weak and looked as though he had a palsy in his hip, knee and ankle. Every muscle group we tested on this side of his body reacted like that. Weak, and when repetitive tests just gave way. So a tumour actually it looks like multiple palsies. It's quite genuine. That curve, the curves are there, you recognise the curves. But it's too many muscle groups, too many joints. And that's you sort of lean back, and the thing that really ticks you off is you know this person's been to other therapists and nobody's done a damn test, which would have picked it up months before and possibly changed the prognosis. But those are the things that, this is one of your functions. And while you do the test properly, you can pick up these serious pathologies and possibly change a potentially lethal condition into, you know, something that might turn around.
So what gives you a weak muscle?
Okay, a weak muscle is going to be like a muscle tear, right? An old muscle tear, it's been ruptured or whatever like that. Or it's rehabilitating from a fracture, an old fracture or something like that. In other words, this is minor, I call that minor pathology. It's rehabilitatable and it's something that's been there for quite a while. So it's not life-threatening. It's not health-threatening. Look at a palsy on the other hand. What are we looking at? We find palsies, tumours, fractures, fresh fractures, subluxations of spinal joints. Now, up in the craniovertebral region, that of course could be potentially lethal. Neurological damage. What is the neurological damage? Is it a tumour? Is it a disc bulge? Is it a disease like MS? What is it? Doesn't matter, does it? You can't treat it. Unless it's a disc, that's the one area you can treat. But most of the ominous things that show up as palsies, you have to get rid of them. That's why we need to find them. The weak muscles are irrelevant. I don't give a damn in the scan whether their whole leg is weak. That's not my function, the scan. That's why we spend so much time emphasizing these things. It should take you 10 minutes. And in that 10 minutes, be able to turn around and say, oh, well, that's good. I'm relieved that this patient has no serious pathology. Whatever they do have is minor musculoskeletal. A lot of pain, maybe, but in terms of health, it's minor. And they say, okay, now we'll spend the rest of the time looking for this pathology and find out where it is and get rid of it. But if you run into enough, because I see a lot of chronic patients, I'm at the end of the line where these tumours do come in. And I make damn sure that if I see a patient who's been on treatment for a long time, wondering why they're not getting better or they're getting worse, is it a tumour? It's a real possibility, and you've got to remove that possibility. If you don't, you're just like all the others. So this is the one I'm after. When I do that muscle test, I'm focused on fatigability, because fatigability is a serious sign. It can be nothing good about it. Whereas weakness, no, maybe I had flu last week, and now they're weak. So what? That's not my. That's not a major problem. Generally, you only do this once in a scan, but you can do repetitive testing if you need to write reports, obviously, or you can do it if they're getting worse and they're not getting better. It's like, okay, when I first tested them, that was negative. What about now? They're complaining of more pain down the leg. They're obviously losing movement. We test them now. Now we find the palsies. That's a major breakthrough in terms of finding pathology. This thing is getting bigger. Again, nothing you're going to do about it. You've given it your best shot. Get rid of the patient. That's your function. Protect their health. So these really are like medical tests, if you like. That's what we're looking for, and we hope it's all negative, because it makes life a lot easier. I mean, physically it's harder because you've got to work on them and get them better. But if you're trying to treat somebody and they've got this hidden pathology that hasn't surfaced, then they're not going to get better. In fact, you may be responsible for them getting much sicker. Okay. One other thing. The way you test is extremely important. Again, can I use you? So, because I know Randy knows what I'm about to do. So that would be unfair to use him. Please, lie on your side. Bend your right knee up. Just come back a little bit. Good. I am now going to do a test. Two tests. So I don't want you to look behind you, okay? And I am going to predict his response. Okay, lift your knee up for me. Now I'm going to try and do these in what look like identical ways. But there will be one subtle difference. And I want you to see if you can pick it up. Okay, don't let me push your knee down. Hold against me. Hold, hold, hold. Relax. Relax. Just give him a little break. Okay, lift your knee up again. Now, don't let me push your knee down. I want you to hold, 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 hold. Up again. Don't let me push your knee down. Hold, hold. Relax. You okay? Don't want to give him a tendinitis. Lift your knee up. Don't let me push you down. Hold it. Was I right? Did you notice any difference? Other than you were weak and strong? Yeah. He doesn't know why. Doesn't know why. Anybody see the difference?
Leg versus knee?
No, I tried to say don't let me push your knee down each time. I came up onto my... Yep, no, I leant down here and I pushed down each time the same way, up onto my toes, and just leant on him. And then when he was strong, as you notice, it was really hard to try and break that hold. Or when he was weak, just my leaning on him broke his hold. And he couldn't do anything about it. And he doesn't know why. They're so subtle. It's rotten testing. In the first one, don't let me push your knee down. Hold. He's strong. Relax. This one, get your leg up. Don't let me push down. What's the difference? Me. I'm up against him. I touch him. That's all I have to do. I touch him and he goes weak. This works male to male, female to female, male to female, whatever. It doesn't matter. It's a physical thing. It's not a sexual thing. And I noticed it in an exam. I was in, we were examining this, and one of our models was not appropriate to be treated because she had some problems, so I had to be the model. So, strip my shirt off, I'm sitting there, and this physio is doing testing. And she came up behind me like this to do abduction of the shoulders, C5, and went like that, and I just couldn't hold, and I thought, gosh, she must have blown in my ear. Does it to me every time. And what it was that and she came up behind, she actually leant on me. Now, I thought, well, of course that would weaken any man, but it's not true. It's a physical thing. Watch this on your back. Pull your leg up, your toes up. Don't let me push down. Come on, hold it, hold it, hold it. Good and strong, yeah? Watch your sloppy test. Don't let me push down.
That's not fair.
It's not fair, but it's accurate. He's weak. And that's going to dramatically affect my results.
What if you couldn't break the person? You know.
Yeah, use it deliberately. I normally say that if you need to, you can always use that technique.
Okay.
As long as you're consistent.
Okay.
And you do it everywhere. That's kind of difficult. This is where we get into these areas, like, you know, in terms of make sure you're doing the test. You notice with all the tests I was very distant, no touching, no leaning on him. Those are accurate tests. You start to get sloppy, you get inconsistent results. That's not good. Just while we're on the subject, just for a bit of partying around, because you go on some of these courses and they go into the mystical things, you know, all these dual tube courses and various other things. Sit up for me. In a level 5, if any of you are brave enough to go that far, swing your legs over. We do a course that is literally into these other areas, using, actually you can switch now, I'll use Randy. I'll demolish him. But I don't think he's seen this one. While we're into all of this pragmatic stuff and absolutes, I want to show you some of the less absolute material that we'll run into. Lie on your side for me. I'll use the same muscle grip, head to the other end. Good. Bend this knee. Just a prediction again, I'm only going to do that 3 times. Oh, that's strong. And that's good. Keep your arm, just keep your arm there for me. Good. Lift your knee up. Don't let me push down. Hold it. Relax. Not recommended on patients. Okay, get this knee up. Don't let me push down. Come on, Randy, you can do better than that. Not touching him. He'll tell you if I touch him. Come on. Come on, let's go. Okay. Now, I'll explain this in a minute. Okay, get this leg up. And hold it. Weirder now, right?
Believe it or not.
This is acupuncture. Applied kinesiology. Each meridian has a key muscle. Key muscle of the large intestine meridian is the gluteus medius. If I enhance the flow of energy, I'm talking these terms. I was an acupuncturist before I became a manual therapist, so that's why I use a lot of this stuff. But if I enhance his energy, I can make him even stronger than he is normally. But if I sedate the meridian, I'm just going in the opposite direction to the flow of energy. This is the way that the acupuncturists talk. Then I can weaken him. So there's a lot more out there that you are going to learn, and a lot more weird stuff. And to me, because this is the way I was sort of brought up professionally, thinking in terms of balance, energy balance within the body, and that's very real. Health is balance, and people go out of whack, they're out of balance, and they're going to become weaker. That's one of the signs why we do these muscle tests. Weakness can never be a sign of health, ever. So we do that sometimes to get an effect, enhance strength and so on. Years ago, of course, we tried this on athletes and all sorts of interesting results. We'll go into that, as I say, in the later levels, but be aware that even when you're doing this strength testing, some of this stuff can be not quite right. So don't, if you find something's out of whack, there's a test there that you thought should be negative and it was positive, or vice versa, and it doesn't fit anything, just log it. Don't get upset by it, just log it and remember it, because some of these other things, like, can the neck affect leg strength? Yes. There's a back condition, back pain, acute low back pain, tends to affect the younger people. And they have a lot of pain, full range of motion, no restriction, everything's negative, no weakness. Where is it from? Atlanto-occipital joint. So when you listen to these people that are doing myofascial stuff and everything else, and they tend to sort of mystify it in this aura of, you know, mumbo jumbo, you've got to remember that this is all neurologically based. Most of this stuff is linked up by nerves. Now, we may not know exactly the pathways, but we know there is connections here. When you get to your level 3, we emphasize relating areas of the body to one another. Like, is it possible that somebody who sprained their ankle and has an instability down here, could that be related to the headaches they now are getting? Yes. How that happens, we'll explain to you later, but just accept the fact that it does at the moment. So although I might deviate there, it just makes a little bit of an interesting break from having to learn all these facts. Now I've totally confused everybody. Let's look at the next part of the testing, which would be reflexes, while we're on muscles. Do we have any reflex hammers? Great. Reflex testing, or tendon jerk reflex testing, is done to test the monosynaptic reflex. Goes from the muscle spindle back to the extrafusal muscle fibers to give us the reflex jerk. In the lower limbs, it's one of the first things to go. So we can often lose a reflex and not have a weak muscle, or not have an evident palsy. And the palsy will come in later. In the lower limbs, once we've lost a reflex, it tends not to come back, even though the person is fully rehabilitated. The upper limbs is quite a different story. Even in the presence of gross wasting and terrible weakness through palsy, the reflex can still be there, and often is quite brisk. And even though it may disappear with, as the palsy encroaches more and more, it can come back, and frequently does. So they're quite different. When we've asked the neurologists to explain that, the only thing they just shake their head and say, it must be a length phenomenon. That's the only thing that separates them. It's the length of the neurons. It must have some bearing. Lie on your back for me. So it's going to give us a little bit of advanced information, possibly, into the neurological state. And what can cause a loss of reflexes? Apart from a palsy, is there any other, well, say a nerve root palsy, any other condition? Yep, so that would give us a root palsy. But the other thing, of course, is a nerve trunk palsy. So he may have been damaged somewhere outside. So if it fits in with the rest of your findings in terms of segmental weakness, then that's great. Otherwise, if it's an oddball finding, it may well be another injury or another condition. Many people, I'm sure you're aware, don't have a reflex that can be initiated. You go all over them and they look dead. Totally negative. Well, you don't sort of shake your head and say, oh well, that was a waste of time. Because at the other end of the spectrum is a condition or a state called hyperreflexia. Hyperreflexia indicates what?
Upper motor neuron.
Central neuron.
Upper motor neuron disease.
Yeah.
We say disease, but it could be a disc in the thoracic spine. What is the implication of finding upper motor neuron signs in the legs when we test? What does that tell us about the lumbar spine? Tells us it's probably not involved. Where does the spinal cord end? Yeah, about the mid-body of L2. So discs 1, 2 hardly ever happen. So if we've got cord compression, it's more likely to be up in the thoracic spine or cervical spine. And it's an inadvertent finding. I've done this before. You're testing somebody routinely, you're looking at their back scan, hyperreflexia, clonus, Babinski, and it's like, wow, what the hell are we dealing with? And it will pan out to be a neurological condition like MS or something like that. So when you find negative reflexes, means they don't have upper motor neuron problems. It's a big negative. It's not a total waste of time. The important negative is the one that is the odd man out. All of the reflexes are there, but I can't get this right quadriceps knee jerk. That's an important negative. That's the one that will tell me, okay, I have hyporeflexia or areflexia, absence of a reflex, or weak reflex. We can't do the L2, unfortunately. Take an awful hard whack to stretch Zoas. But we do 3, 4, 5 and S1. There's a lot of discrepancy in terms of how many times do you do the reflex. If I do that once and I get a response, that's it. The reflex is there. Isn't that what I'm supposed to be finding out? It's the reflex there, isn't it there? Repetitive testing is said to be done by some people to fatigue, to see if the reflex fatigues. Anybody done any of the work by...
Grimsby does that, doesn't he?
Yeah, some people do that. Anybody run into Rude's techniques, neurological techniques? Do you know how she facilitates muscle activity? Repetitive reflex testing. So trying to facilitate the quadriceps. Come on now, lift. It doesn't fatigue, it's impossible to fatigue it. It enhances it. So once you've got it, once you've got the response, once is enough. We allow 3 goes. It's like playing darts, you know, where you go up, off to the left, off to the right, and then you get it in the middle. That's what you're going to be doing. So you've got to be a good shot. So we take into account that you might go, oops, sorry, oops, I'm sorry. So we'll give it 3 shots, and if we haven't got it by the 3rd one, we'll say, okay, it's not there. Notice it's a very brisk, sharp action. Again, so much of this stuff, the success of this, is your technique. Not being sloppy or doing the wrong technique. When I made a terrible mistake a few years ago, I allowed my wife to be on one of the courses. And my wife is a neurophysio, that's her specialty. But she was quite aware of the fact, because we worked on patients a lot together, that some of the hemi conditions, especially the shoulder and everything, could do well on manual therapy. So she wanted to get into the stuff. So she came on one of the courses, and I'm doing this, and I demonstrating a reflex, and from the back of the class comes, oh my God. Of course, everybody turned around like this, thought that was very funny. She said, what are you trying to do? That's assault and battery. Because like many manual therapists, I didn't really have a clue about reflex testing, other than I know you have to hit the tendon. And this is the way you see some people doing it. Like a judge. Bong! If you do that on some people, Randy's quite brisk, but in some of the people who don't have such brisk reflexes, you won't get it. Because that thud doesn't produce a rapid enough stretch. It's got to be bing, like that. So now I do it properly. I've got her approval. So it's brisk tap, like that. Once I get the reflex, that's fine. L4, I squeeze into the adductor mass, going for adductor longus, with my fingers over the tendon, and I hit through my fingers. There's the reflex. I'm sorry, that's L5, not L4. The crossover in that part of the adductors is where you're getting a crossover between the hamstrings and the adductors, and for some reason that supplies 5. 4, of course, is the dorsiflexion, where we tap over the tibialis anterior, and all you're watching for is that tendon response there, where it goes into a little bit of inversion and dorsiflexion.
What level is that?
I'm hitting, that's 4, so it's 3, 4, 5, and then S1. Sorry, that was my mistake. Hope I didn't confuse anybody. So what I'm doing here is I'm aiming over the navicular, which is where the tendon attaches.
Which tendon is that?
Tibialis anterior, which of course is L4. S1, pull the tendon into a lengthened position so it's fairly tight, but notice again, hand position. There's another nag, nag, nag. Your neurotherapists like that. Don't do this, because it will produce the wrong reflex activity. Under the ball of the foot only, with as few fingers as necessary, and then pull up. Sharp tap on the Achilles tendon. Grading those reflexes. The doctors will grade it from 0 to 3, where 2 is normal. 3 will be hyperreflexia, 1 is hyporeflexia, 0 areflexia. The neurotherapists in Canada, in a way, grade 0 to 5, where 3 is normal, and then the reason they do that is that 4 is exaggerated reflex, 5 is hyperreflexia. What's the difference? One's a sinus spasticity or upper motor neuron disease. Exaggerated reflexes can occur as a result of irritation in the spine. It's called a facilitated segment. The reflex is no faster than normal, which you get in hyperreflexia. All that happens is you get too many motor units involved, so you get this strong contraction, much more so than any of the other groups. What's the other feature of testing hyperreflexia? Anybody tested a Hemi or MS patient? What do they do? If I was doing that on him, what would he do?
Clone it?
Yeah, you get this reverberation. We do that and it goes like that. That's a spastic reflex. Whereas with an exaggerated reflex, it comes and it dies down straight away. So those, they're different. Then we have again, hyporeflexia, sluggish reflexes, which are at the other end of the scale from the facilitation. So we get this if you have a palsy, you get this very slow response. It's like, instead of being rapid like hyperreflexia, you tap it and it goes, oh, it's like an effort. In a hyporeflexia where you get the same, it's brisk, but a very small number of muscles involved. That's the other end of the spectrum of the facilitated segment. So you've got all these other things, but basically the ones we're interested in is the isolated absence of a reflex or hyperreflexia. That's the ones we're interested in the scan. Other neurological tests or reflex tests that we'll do, again for upper motor neuron, is clonus. clonus is an reverberatory response to rapid prolonged stretch of a muscle. That should indicate how you do it. So this is no good. Neither is that. It's got to be rapid and hold. You notice there, Randy gives me a little point as we do it. Stretch reflex. In some patients you'll get 2 of them. That's normal too. 3 is starting to get questionable. 4 is clonus. So the patient's foot goes dud, 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 and dies off. Now, has anybody done this on a neurological patient? What happens to them in a hemi? When you do that test, what do? They keep going, yeah. Just like Duracell. Keeps going and going. So if you had a hemiplegic patient, and they just do that. That's, when their foot gets in the wrong position. But orthopedic clonus, or I should say upper motor neuron conditions from orthopedic causes, is quite different. It can be very temporary. A thoracic disc impinging on the cord. We do the reflexes. See, a thoracic disc is a kind of an issue because, of course, it's going to give you backache, low backache. So you may be investigating the lumbar spine first, thinking it's a lumbar problem. Find nothing in the lumbar spine, and then bingo, you hit this. You think, wait a minute, I'm in the wrong area. So you get this response where he goes one, so it reverberate like 4 times or more, but it dampens it. The Golgi tendon organs can still overcome it because the spasticity isn't that strong yet.
Earl, so doing that, having clonus like that on dorsiflexion could be an upper motor neuron than a thoracic.
It's an upper motor neuron condition. If it's associated with back pain, which was associated with some kind of injury, lifting or whatever, then my mind is ticking over. I have to complete the lumbar scan. I'm in the middle of it anyway. I'll keep going on that. But in the back of my mind, I'm now thinking, boy, I must get up into the thoracic spine and start looking at that. What other test, of course, would have been positive already if it was a thoracic disc? Yeah, the dural test, especially the slump test. Some of you young patients who have thoracic discs, the slump test is the only test that picks it up. And the key feature is they're dorsiflexing their leg like this, and they're feeling it somewhere in here. Not leg pain, right up in here. They're saying, oh yeah, that really hurts my back. Putting all those things together, positive slump, hyperreflexia, it'll be enough for me to phone the doctor. Babinski's response. Or positive plantar response, as they call it. You can't have a positive Babinski. You have your wrist slapped for that by the neurotherapist because Babinski's response is a positive test, so you can't have a positive. So we've got Babinski's response, which is an extending toe, an extending hallux, with fanning out of the lesser toes in response to a noxious stimulus applied to the weight-bearing part of the foot. It's a bit wordy, but you need that because in your exams you often get asked that, okay, define these terms, so that would be the definition. The weight-bearing part of the foot, that's easy, right? The yellow bit. And the reflex response to doing this is so very different from this. Noxious stimulus, I like that term. There it is, sharp point. Can be your thumbnail if you want, but that's what that's pointed for. Starting at the heel, we'll take it all on the lateral side of the foot and then across the metatarsophalangeal joints. Fix the leg So you've got to be fairly firm, don't draw blood, but be fairly firm on the sole of the foot.
Does speed matter much with that test? You know the speed
No.
at which it's elicited of the movement of the...
No, I think it's just done at a reasonably slow speed. People with very ticklish feet, of course, they will do with a withdrawal response. Concentrate on the toes, that's what you're looking at. Look at those toes, never mind this business, this response. We can get similar responses in some of the more chronic conditions, especially neuro, by doing a squeeze on the tibia, very painful. Squeeze like that, you get the same Babinski's response. Or what they do is sometimes they rub up the, with your knuckle, rubbing up on the shin, I mean, the noxious stimuli, and that's the response to it. We can also get clonus in a more chronic case in the quadriceps. Sometimes you don't get it in the calf muscles, you get it in the quadriceps. So there's an alternative one just to show you, is to take the patella down like that. Same thing, a rapid movement and hold. And you get that kind of response. We saw that in the patient who had spinal stenosis in the thoracic spine. It wasn't a disc, it was a stenotic condition, narrowing of the canal. And that's one of the ways we picked it up. We thought it was MS at first, but it turned out to be stenosis of the thoracic spine. Okay. So those are the reflex tests. We'll practice those, see how good you are at picking them up. And of course I'm demonstrating on one side, but you always do both sides, not to compare necessarily, but just to make sure that all muscle groups are tested. Any questions? Okay, let's practice. Where are the hammers? Go on. Okay, there are the hammers, so let's go. This one's been worn down. Okay, Randy, can we just... So now we come to the sensory testing. So we're testing skin sensation. And for this we need to understand the various sensory pathways that we have. And we have a spectrum of sensation ranging from what to what? Well, you can't feel nothing. What's next to nothing? Very light touch. Would you agree with that? Yep. Very light touch and painful stimuli. That's the other end of the spectrum. And in between that, we've got your vibration, your heat, your cold, and so on and so forth. But the two ends of the spectrum. So we know if we use very light touch and they can feel it, that they don't have the other bits of the spectrum missing. If they can feel that, then they'll certainly be able to feel pain. So we don't have to start sticking them with a needle. So we'll use light touch, and if that's negative, that's fine, that's the test over. Let's define light touch though. Light touch will be sensation delivered to the skin which does not deform the skin. As soon as we deform the skin, then we are bringing in other mechanoreceptors and all sorts of other things. That's not light touch anymore. So, if we don't deform the skin, what is it that's picking up that sensation? If I do that, what is it that's picking that up?
Sensory?
Where? In the hair, yeah. Normally it's the hairs that are picking it up. Which is why you can't use that soles of the feet. No hair there, have you ever noticed? Old English expression. First sign of madness, hair growing on your palms and soles. Second sign of madness, looking for it. So, we have to use a different test, in other words, when we come to the foot. We use our finger. We can still get a fairly light touch, but not deform the skin. So we need a heavier sensation. So the lightest touch, what's the lightest touch that you normally experience?
Air.
Yeah, a breeze, right? You can pick that up, not just because it's changing temperature, you actually feel it. So blowing would certainly be good, except, you know, when you get higher up towards the groin, that's not a good idea. Now, so what we use is a piece of tissue paper. And we say to the patient, in an area we assume they can feel, you know, I'm going to touch you with this tissue paper. And every time I do, I want you to say yes or ha-ha, or just indicate that you feel it. So we get them to close their eyes and then we will start. Now you have to know the dermatomal areas, and L1, which nobody ever bothers doing that, they forget about it. Very definite. If you've seen anybody with shingles over L1, you never forget that supply. It's very large all over this area of the body from the front to the back. So fairly large dermatome. So start up in this area just with some light strokes. L2 is going to be on the inside of the thigh. L3, fairly long, can go all the way down to the ankle. L4, side thigh over the outside of the knee, and then it crosses over towards the inside, up towards the big toe. So all the dermatomes all spiral. So what I'm doing is I do each dermatome. That way I know I'm not going to miss anything. The worst form of testing is this. Because of the dermatomal overlap, you will not find any positives. Makes life easy if you don't find a positive, but it's not very good therapy. So we're following the dermatome round. That's L4. 5 and S1, they have a similar supply above the knee, so we don't have to retest that. But at the knee, here's 5 coming down the front of the shin, and then over to the middle 3 toes. Here's S1 coming down the side, going to the little toe. Testing the foot. Nerve supply of the foot is interesting. Helps us sometimes to separate some of the peripheral injuries from nerve root injuries. One of the ways we can separate L4 from L5, because their nerve supply is so closely linked geographically, is that L4 never supplies the sole of the foot. So if in association with a numbness here in the front, above the ankle, is sometimes where they get it. Or if it was a second toe, for example, that could be L4, L5. Do they have any numbness in the sole of the foot? If they do, then it can't be L4. L5 supplying this area on the medial side of the foot, S1 on the lateral side of the foot, and generally S2 on the heel. If I find an area where he doesn't respond, so look at a typical L3, which is sometimes around the knee, you pick it up, and he doesn't say anything, go above it, below it, yeah, I can feel that, yep, yep. He misses it again. Now I have to test. I know he's lost his initial sensation. Has he lost the ability to feel pain? Well, we don't really want to give him a lot of pain. It doesn't matter what you use. But don't use pins. Pins are out now, thanks to various viruses. They did a study, I can't remember which hospital it was, anyway, somewhere out in East, where they suddenly did a surprise visit and said to all of the doctors, the residents and so on, we need your pins. They took all of the pins and tested them in the lab, and they were horrified at the amount of bacteria and viruses that were present on these things from pricking people's skin. So they recommended that after that time that either you use a disposable needle, which many of them do, or you use a paper clip or something like this. Yeah, plastic fork. It's great because it has a bit of a sharp point and a blunt point. We say, and it doesn't matter what you use because you're going to start off again and say, okay, you feel that that's sharp, yep, that's blunt. Now I want you to, or is that both sharp? Got a point on it. That's blunt, sharp. Okay, and I want you to tell me. Now we just concentrate on this one area. That's the only bit that was suspect. So okay, you tell me. And it goes sharp, sharp, dull, dull, sharp. What you're looking for is the fact, sometimes they can't feel it at all. And you know, you can see him looking expectantly. He wants to feel something, but you can't. Or the sharp feels dull. So he thinks you're doing dull all the time.
At this point, are you deforming the skin now?
Yes. This is the other end of the spectrum. So we're actually trying to produce a noxious stimulus. A mild noxious stimulus anyway. I remember one of the, I had a young teacher who was getting into the business, who was assisting on a course, and they said, well, I'd like to do something, you know, demonstrate. And I said, okay, well, demonstrate, you can do the scan, and we'll go on from there. So in demonstrating the scan, she's very nervous, and with this pin, perfect model, didn't flinch. And she's doing this and saying, and this is how you're going to test the sensation. Well, and then she carried on talking, and as she's talking, this blood starts to appear, and all of these points, and of course everybody's looking at it like... So we had to make a point of saying, you know, you don't really have to do it that hard. Don't enter the skin, just deform it a bit. Okay. If we find numbness, the key then is to try and work out what is the cause of it, because peripheral nerve problems can give us numbness, central nervous problems, upper cord problems, and nerve roots can all give us problems. Then in your handout you see a whole slew of conditions, various neurological conditions that you have to distinguish between. But the key is going to be, does it fit? If I have numbness in the knee, do I have a corresponding weakness of quadriceps? That might say, okay, that's L3. What would be the nerve supply if I found the numbness in here? What would be the peripheral nerve supply? Tibial nerve, this area here. And what about the dorsum of a foot? No. No. It's one of those nerves that you've forgotten about. It's one of those black holes. Sural, good. Sural nerve. Higher up, of course, we can get the saphenous nerve involved if we have numbness higher up. And, of course, the common peroneal on the outside. So don't forget those guys. They are also capable of giving us numbness. But if it's a peripheral nerve, the muscular component is going to be quite different. In most instances. For example, common peroneal nerve will give us what weakness? Common peroneal nerve palsy. Eversion will be lost, and dorsiflexion. Now, what can you say about those two? L4 and L5 and S1. They're too far away from each other to be a segmental nerve supply, right? They're in different segments. And that's how you separate it. If dorsiflexion and eversion are lost, then it's more likely to be a peripheral nerve palsy rather than a root palsy. Nerves have got all mangled up by this time. By the time they're down there, and they're mixed. Nerve root, if it was an L4 nerve root, which muscles would you expect to find weak? Anterior tips, good. Go with dorsiflexion. Inversion. Anything else? No, not really in the calf. I would look for maybe quadriceps weakness, adduction weakness, and that kind of thing. Give me a few alternates. See how extensive it was. So that's the difference. They're quite different muscles, aren't they? From what would be supplied by the coron-peroneal nerve. So it's where your differential diagnosis comes in. But unfortunately for you, differential diagnosis requires an acute knowledge of anatomy. So you're going to have to, and I know and sympathise with loss of memory on those things, because it's the same old story. If you don't use it, you lose it. And hopefully in doing scans, when you're thinking about those things, okay, what could that be? Then it will rehash this stuff up again and you'll remember it. Then you won't have to struggle as much. But I'll give you a little test after lunch anyway, and we'll just see how well you can differentially diagnose some of that stuff. Okay, and the other S2, which we haven't done, but which we would do in prone, lie on your tummy for me, will be down the back of the leg, so that would complete the testing of S2. Now this is normally where you're going to find it, in the heel area, rather than up in the thigh. Any questions? Good. Close your books. Find a partner. One person on the bed, one person standing by the bed. We'll have a bit of a pressure learning situation.
Is that possible?
Pressure teaching, anyway.
What is it like when you're looking at like a 45, 50-year-old male compared to...
Okay, if the history has suggested vascular involvement, then we might like to do some vascular tests, but we don't do it routinely in the scan, only if there's an indication for it. So what am I hinting at? What kinds of things will the patient say that might make me want to test circulation? Yeah, very cold feet, very hot feet at night. What's hot feet at night a symptom of? Well, their legs feel burning at night. Intermittent claudication, good. Berger's disease or intermittent claudication. Any other things they might be saying to us?
Swelling.
Yeah. My legs swell certain times, you know, and they feel so big I can't get my shoes on. Anything else? Cramps, yeah. And how do they talk about what kind of things do people say when they're getting these cramps? So what's an ischemic pain sound like from a patient? You listen to it and you think, that's ischemia.
Pressure.
Can be pressure. I'm thinking more of this cramping feeling. They don't describe it like that. They talk about a vice. Oh, it gets me in that calf. It feels as though I've got a vice around me. It burns. Those things are not ordinary symptoms. And you're listening to that and thinking, well, that's unusual. I haven't heard that for a long time. You're thinking of an ischemic condition, like, again, claudication. Ischemic pain, remember, is a sign of arterial deprivation. Commonest one you will be familiar with, of course, will be angina. Cardiac pain, that's ischemia. We can get ischemic pain Where can we get intermittent claudication? In the calf, yep. Anywhere else? The quadriceps, good. That's the one people tend to forget. From a femoral nerve blockage. Anywhere else? See, when you get to the femoral nerve, you think, well, it can't be anything higher, right? Because then it gets too big. There's branches coming off other arteries, which are smaller, but go to very significant muscles. Yeah, you can get blockages in the aorta or the iliac arteries and so on, but I'm thinking nothing as massive as that. Just more common. This would be the inferior gluteal artery. Remember that name? You've got to know this now, aren't you? There's that black hole filled. Yeah, so you get claudication of your gluteal muscles. And we'll look at how to separate those later on. The other thing, of course, which none of you have mentioned, which is a very classical problem, is throbbing. They'll say it throbs at night. It really aches. It's throbbing, just like a pulse. Well, it is a pulse. And what would the throbbing be indicative of normally? Throbbing pain, as opposed to this burning, cramping pain. That's arterial, right? The throbbing, aching, dull aching is venous. So maybe looking at some venous congestion. So these things in the history would tell us, okay, we've got to do some tests. Obviously looking for coloration differences. And then feeling for the temperature. How do you feel temperature? Yeah, back of your hand, that's the most sensitive area in terms of temperature changes. So you don't touch the patient, remember? Don't touch them, just move your hand over them. If you touch them, you have too much sensation coming in, and you don't notice the temperature change, so you're just gliding above the skin. We will look at a swollen leg. Often when you look at calves, you don't know if they're big calves naturally or if they are edematous and swollen. So we use a technique called pitting. We just lightly and gently press into the shin and then release and see if we've left a big pit. Pitting edema would be indicative of lymphatic breakdown and venous congestion. Temperature differences, what's what? What you feel, not what the patient feels. What's a cold limb? Arterial. So what's venous? Hot limb, yep. Warm limb. Bluish look. Remember in the anatomy books all the veins are blue? Right. Just joking. They do actually have a kind of a bluish hue to the leg. And warm. Okay, and then if it's again arterial intermittent claudication, we check pulses. Now, we don't just want to check the pulses and see if they're there in a lying position, because they probably will be. What we might want to do is get them on a bicycle, get them all overheated, or on and off a step, get them pumping until they get the pain, and then test the pulses before and after the pain comes on. So if we have nice strong pulses before exercise and diminished pulses after exercise, it doesn't make sense, does it? When the heart's pumping like mad, they should have a stronger pulse. So if it's weaker, that's the classical sign of claudication. And the pulses that we will use: femoral pulse, felt in the femoral triangle. It's almost exactly midway between your ASIS and your pubic tubercle, so right in the groin. Popliteal, find the crease of the back of the knee, move just slightly below that, right in the middle of the tibia, push in. If you're above the crease, you'll go into the intercondylar space. You can't press the artery, so you can't find the pulse. Very important to be below that, so you can press the popliteal artery against the back of the tibia. That's how you pick it up. Most people miss it because they're too high. And then we have the foot pulses. We can test the dorsalis artery. And the medial artery, which is behind the medial malleolus. That's a nice one to feel, nice and strong. The dorsalis pedis artery, you'll find if you just put your hands over the medial dorsal aspect. I use like 3 fingers because it's so variable, so you can cover that. Can I demonstrate all those pulses? Okay, let's do this. Okay, just undo your short skirt. Okay, here's and you should be able to feel these through underwear without any problem. Femoral one's the easiest one to find, obviously, right over the crease of the groin. You actually see my fingers coming boom, boom up. Very heavy pulse. Lie on your stomach for me. Popliteal pulse. Remember? Okay. Here's the crease of his knee. That tells me where the joint line is, so I know the tibia is just below that. So I find the middle. And again, you're strong enough, you should be able to see my fingers going up and down. Bump, bump. Okay. On your back again for me. The dorsalis artery. You can localize it like this using, as I say, I use 3 fingers, gives me a bigger coverage. Less variable is going to be the medial artery, just behind the medial malleolus. Nice strong pulse. So we'll test those 3 or 4. Get him moving, get him activated, sometimes until the pain starts, and then we will retest them while his heart's still banging away. We would expect to feel those pulses stronger. If they're not, then that could indicate a blockage. Okay, any questions on those? Good. Let's say that's an optional test. Let's go on now to the last part that we're going to look at, which is the sacroiliac joint. Sacroiliac joint had its moment of glory back in the earlier part of the century, when people believed that a lot of the pain in the leg and back and everything was from the sacroiliac joint. Of course, the disc has since taken over that position, and facets are challenging it all the time. So the question is, how much is the sacroiliac joint likely to be involved? It can give us referred pain, because obviously it is segmental tissue, so it can give us segmental reference of pain. Into the S1, S2 dermatomes. So it can look like sciatica. Main difference here, of course, is that none of the dural tests are going to be positive. You can get pain in the front of the thigh. With an inflamed sacroiliac joint, the inflammation can in fact spread into the nerve roots that cross it, which of course are the L2 and L3. And that's a real challenge. That's a nice one to try and work out, because absolutely nothing makes sense. Except when you do the tests on the sacroiliac joint. I'm not interested at all in movements. I don't care at the moment if he has an upslip, downslip, or what he has. What I'm interested in here is diseases. Diseases and instabilities. Both of those will tend to give pain. Diseases are possible in women and men equally. An inflamed sacroiliac joint in ankylosing spondylitis is more common in males than females, even though ankylosing spondylitis is more common in women. And we'll talk about that later. Sacroiliac joint is a male problem. But women can have inflammations from other conditions. And in women particularly, this is the domain of the unstable sacroiliac joint, especially postpartum, or it can be during pregnancy where they've slipped, fallen down on their butt, going downstairs. This kind of thing can happen and lead to an unstable sacroiliac joint. Once it's unstable, then the incongruent joint surfaces that hold it so, the congruent surfaces that hold it so tight, throw the stress on the ligaments, so they become chronically painful. All of the conditions we're talking about will be positive with the following stress tests. So-called gapping test. We are going to take the ASISs in the cup portion of our palm, and then we are going to try and push them apart. This will tend to gap the anterior part of the joint, compress the posterior part of the joint. This one is very useful in picking up ankylosing spondylitis. It's very positive. We can then do rotary stress tests, which are useful in picking up instabilities. The cup of my hand is on the ASIS again, and I'm pushing one up towards his head and one down towards his feet. That will put a rotary twist through the sacroiliac joint. Again, how long do you do it? Varies. A young person, you do it a long time, an older person less, because of the plasticity in the bones is different. But no set time. Just push until you feel all of that plastic movement out. Roll over and face that way. Last test, which is the opposite to the first test. And then we're going to be gapping the back of the joint, compressing the front, pushing down, so. I've seen patients where the gapping test was positive in an ankylosing spondylitis, and this was negative. So this one is less reliable, but the beauty of this one is in picking up pelvic fractures. Your older patients who slip on the ice come in with this chronic hip buttock pain. Pushing down here reproduces that pain. It's quite likely they may have a crack fracture.
Are you pushing directly?
Yeah, straight into the table. Because the greater trochanter will be in contact on the undersurface rather than the iliac crest, then this doesn't do both at the same time. You have to flip them over and do the other side as well.
Is the rotary significant for any fighting? The rotary test?
Yes, is it?
Disability?
Yeah, and what you'll find, like in a woman who's just had a baby, now she's coming in with this back pain, you push like this in a rotary test and you get this clonk. Not necessarily painful, but you can actually feel the thing clonking around. There's some other symptoms associated with that. You need a history of trauma. those conditions, but they also have one classical symptom which is useful, is balance. Balance is terrible on that side if they have an unstable sacroiliac joint. So quite often when you're going to do your S1 test and you say stand on one leg, they do it all over the place like this. Those same patients cannot hop. So, you know, if you want to, you can ask them to hop up and down on one spot. They just fall over because of the massive loss of proprioception from the joint. Okay, and that's all we're doing at this part of the test. This is all we do to the sacroiliac joint. We are not interested in movement tests, just the stress tests. Because only those tests will pick up potential diseases and instabilities, neither of which we can treat. Good. Any questions? Then let's just practice that pulses. So make sure you can find the pulses, and then the stress tests.